Akhtar. She is talking on marble in the orbit, unusual path.
Good afternoon, everyone. Today I'm presenting a case of a rather interesting case where we found marble in the orbit by an unusual path. A patient presented to us, 12-year-old boy with an alleged history of injury to the left side of his face by a homemade firecracker, which in local language is called naal, 2 days prior. He had sudden painful loss of vision in his left eye following the injury, along with an episode of loss of consciousness and 5 episodes of vomiting. On examination, the right eye was found to be absolutely normal with a vision of plane 6-6. In the left eye, there was diffuse lid edema and ecchymosis was present along with complete ptosis. This image might be a tad misleading because in this, the thumb of the examiner is being used to lift the lid for a better view. There was sutured laceration present roughly 2 cm below the left lower lid. The eyeball was displaced inferiorly. Ocular movements were restricted. The conjunctiva was congested with a clear cornea. Pupil was dilated and non-reacting. There was no perception of light and fundus could not be visualized due to hyphema present. First, we sent all the blood investigations which came back normal. Then the patient was sent for imaging. The CT scan showed the axial view with an intraconal foreign body in the left retrobulbar space. Further cuts showed fracture of anterior wall of left maxillary sinus with the left orbital rim. Then we did a 3D reconstruction of the face, which beautifully showed a spherical foreign body in the left orbit. The axial view, sagittal, and the coronal view also showed the foreign body with orbital floor fracture and hemo-maxillary sinus. Then the patient was given a 3-day course of IV steroids, which resulted in reduction in periorbital swelling and ecchymosis. The patient was taken for surgical exploration under GA through an inferior transconjunctival orbitotomy. Retrobulbar space was entered laterally and a greenish foreign body was visualized, which was extracted, and it was found to be a marble measuring approximately a size of 1.5 centimeter. There was a breach in the orbital floor, however no prolapse of orbital contents in the maxillary sinus was noticed. The inferior rectus was completely tethered and therefore no attempts was made to repair it. The child made an uneventful recovery with significant improvement in pain and ecchymosis. These are the photographs of post-operative day 3 and they showed significant reduction in inflammation. The extraocular movements recovered in all but the down gaze. However, no visual improvement was noted due to CRAO. This is the image of the patient 1 month post-op. The wound site was healthy with no signs of inflammation, but the eye was still in ptosis with no gain in vision. Sadly, the patient didn't turn up for follow-up after this. Coming to a brief discussion. Retrobulbar foreign bodies are rare but potentially sight-threatening ophthalmic emergencies. They can be caused by a variety of mechanisms, including penetrating trauma, RTAs, or occupational hazards. Clinical picture can vary depending on size, composition, and location of the foreign body. Early diagnosis is essential and a thorough ophthalmic examination, including imaging studies, is critical in detecting its presence and location. If left untreated, it can lead to optic nerve damage, permanent vision loss, or even life-threatening complications, such as orbital cellulitis or cavernous sinus thrombosis. Management includes prompt removal and appropriate management of associated injuries. Surgical intervention may be required and the method of removal depends on the size, location, and nature of the foreign body. So, in conclusion, this case highlights an unusual orbital foreign body following an unusual injury via an unusual path. It emphasizes the need for maintaining high index of suspicion in patients presenting with ocular trauma. A timely intervention can prevent significant morbidities associated with these kinds of injuries. Thank you.
What was the route of entry of the foreign body? From
Ma'am, through the maxillary sinus.
Through the maxillary, from which side? Inside or from that skin area?
The laceration which was seen, it entered through that 2 centimeter below the left.
Then it went into the retrobulbar space.
So what do you plan to do for the residual hypotropia and ptosis?
Ma'am, for ptosis, we can do any of the ptosis correction surgeries with the patient, but the main concern for the patient was loss of vision. He was not concerned for ptosis that much. So that was maybe also the reason we lost the patient to follow up.
So, very well presented. Aligarh, I usually expect a socket case. In a way, it's a socket case, right? So, pre-operatively, you didn't do an X-ray, you did a CT scan,
Yes,
which is
I did.
great. If you did not have any history, are you able to identify the material based on CT scan?
So yes, sir, by the density of the material, we will be able to identify what kind of material it is.
How will you measure
guess.
density of the material?
So by it's hyperdense on the CT scan.
Compared to?
So compared to the bone, compared to the soft tissue surrounding it, that's
You say anyway, anybody? Ushak, you want to teach us?
Hounsfield unit, sir, chatting.
Hounsfield units. Sir.
Did you measure the Hounsfield units for this foreign body?
No, sir, I didn't measure the Hounsfield.
Right, so that's a very practical tip that you want to say, because sometimes patients don't come with a history. And that's a very useful tool to figure out what kind of foreign body it is. Of course, when you're going to take it out, that's fine, but a lot of times we can't take it out.
Yes, sir.
And you want to know ahead of time, so well done. Thank you.